Look today to learn indications and effectiveness for prophylaxis. We'll look today as well to recognize the cutaneous as well as the extracutaneous manifestations of Lyme disease. And then we'll go and try and teach ourselves a little bit about the understanding or the controversy surrounding chronic Lyme disease. So as a brief outline, we'll go over Lyme disease as a whole. We'll do some case illustrations to help describe some of the intricacies with management and diagnosis, and then we'll, again, jump into the controversy. So thanks for filling out my survey. About 40% were staff, 60% residents, and about 55 responded. A couple more added, but I didn't have the time to have the responses. Most of you said you were okay with the topic of Lyme disease as a whole, a few on either side, but I think one or two on either end. Who's the super duper one? No? About 40% of you said you had diagnosed someone with Lyme disease in your career. In the past year, a lot of you have dealt with patients seeking advice regarding treatment or prophylaxis after a tick bite. And about 40% of you had seen someone with chronic symptoms asking about either extensive treatment or investigation for Lyme disease. And most of you are aware of some of the controversies surrounding Lyme disease, and I'll show you what I know, and we can maybe fill in the blanks between what you know. For those of you who know the IDSA guidelines, most of you said you would follow them, some of you said you wouldn't, and some of you said you didn't know anything about them. For those who said you would deviate from them, if we have time at the end, maybe we can talk about that. That'd be interesting. So a brief history on Lyme disease. It came out in the 1970s in Old Lyme, Connecticut, where a couple mothers were concerned that a bunch of kids had an unusually high incidence of juvenile rheumatoid arthritis. So the Connecticut Health Department was commissioned to investigate this, and Dr. Alan Steer looked into this and originally described what was called Lyme arthritis. He soon found that it was actually more of a multi-system disease, so he called it Lyme disease. And he realized that the kids were mostly related to wooded areas, so they started looking towards ticks. And it took them 11 years. Dr. Willy Bergdorfer, a microbiologist, eventually figured out that it's a tick-borne spirochete that causes Lyme disease in the U.S. and Europe. So spirochete was named after him, Borrelia burgdorferi, as you know it. So Borrelia burgdorferi as a whole is used to describe Lyme disease worldwide. We use Borrelia burgdorferi in the United States, and that's the strict name because that's the strain that we have in North America. There are a couple other strains there, Guerini and Afzellia, and they're a little different, but we're not going to talk about that today. The vector, as you know, is Ixodes scapularis. In the west of America, there's Ixodes pacificus, and it's a little different because it feeds on lizards, so it doesn't transmit quite as well. There are other ticks in Europe and Asia, and there's other ticks that you may have heard of, such as amblyomma and dermacentor, that are responsible for ehrlichiosis and Rocky Mountain spotted fever, respectively. The reservoirs are field mice, and those are the major reservoir because it acts to amplify the spirochete when it's infected. The birds play a bit of a role with acting as a reservoir, but also acting to spread the disease. White-tailed deer are important for the life cycle. They don't actually cause amplification of the DNA or the spirochete, but the adult does require it to sustain its life cycle. Your dogs are susceptible to this disease, but they don't spread it. So let's play a little bit of a game. Which one of these is the tick that we're concerned about? Who says A? B? Need some commitment here. C. Holy cow. And D. Some of you guys are really smart. Here we go. Okay, so looking towards our good Bible here, you first start with whether or not they have a scutum. So that's a shield. And so if they don't have a scutum, they're soft ticks, that's not what we want. If the scutum is present, then we look to the body. Are they short and stout? If yes, then that's amblyomma. The other key to amblyomma is it has a little spot on it, so it's called the Lone Star tick. And the long oval bodies are where the money's at, so you compare the long mouth parts versus the short mouth parts, and the long mouth parts are where the money is at. So now you're experts, right? So now you can all explain to me, those who did not get this right, why A is a soft tick, B is a Lone Star tick, or sorry, D is, B is a dermacentaur tick, and C is our culprit. Very good. So transmission, this is actually very important when you start talking about, when you have patients coming into the ER and how to talk to them about prophylaxis and transmission. If they're attached for less than 36 hours, the rate of transmission is essentially zero. They've correlated transmission rate to time as well as engorgement, and they've done this in very nicely done animal studies. And there's also this large prophylaxis study in 2001 where they showed that if the tick wasn't engorged at all, you had zero transmission, and as the engorgement increased, your risk increased. The other thing you can use from this study to help have a discussion with your patients is that in this hyper-endemic area in New England where they had this study, the overall risk of every tick bite that came to this study was 3%, of getting erythema migrans and of getting Lyme disease. So just to put it into perspective here, there's your unfed tick. There's a tick that's how it looks at 24 hours, and this is what it looks like at 36 hours when there is possibly some risk of transmission. 72 hours, they start looking real nice. And this is, that's nasty, right? Oh, imagine that was on your leg. So, as we know, these ticks are in New England, Northeast America. They're in North Central America. But they're also here. So they're in Western Canada. There's a cluster here in Winnipeg, and there's a cluster here that so happens to be our region because it's right here in the Ottawa area. So this is a 2016 risk map of Lyme disease and Ixodes scapularis containing Borrelia, and Ottawa is right there. So Ottawa and west of Ottawa seems to have the ticks that are involved, and we're deemed a risk area, so it's coming. And there's been news reports of more and more tick bites and Lyme disease in the Ottawa area. Cases are obviously going up in Ontario in the last several years. It does happen to occur mostly in the summer, which makes a lot of sense. So let's talk a little bit about clinical manifestations now. There's three typical classic manifestations or phases of manifestation. So it's the early phase. You have your erythema migrans, RAS, plus or minus a flu-like illness. You can then move on to an early disseminated phase, which the way I remember is neuritis, carditis, and arthritis. But the neuritis part or the neurologic part is broken down into cranial neuropathies, lymphocytic meningitis, radiculoneuritis, and sometimes an encephalomyelitis. The late stages for neurologic is mostly a peripheral neuropathy and a stocking glove distribution or an encephalopathy, and you can get a waxing and waning chronic arthritis in the late stage. The problem with Lyme disease is that you can go to any stage without having previous signs of the previous stage, which feeds into the bit of the controversy, and as well as other things like arthritis without arthralgias without arthritis. I'll touch on the arthritis a little bit here because I don't end up describing it later, but it tends to be arthritis, large joint arthritis of the knee. It can be one or both. It can affect other large joints such as the wrist, shoulder, and in some cases described in the TMJ. So just to illustrate for you guys, there's your early phases, there's your early disseminated phases, and your late phases. And this goes to show that this just illustrates that the early phase is much more common to see, and then the early disseminated is less common, and then late even less common. Your serology accuracy or sensitivity increases as you progress through your disease. And we'll just come back to this for a point of reference for other case illustrations later. In Canada, erythema migrans is the most common manifestation of reported disease, followed by arthritis, neurologic problems, and then finally carditis. So the way we describe cases, or the way we define confirmed cases by the CDC is erythema migrans plus a known exposure. That's a slam dunk. But if you have erythema migrans without a known exposure, they say you need to confirm it with serology. And if you have neuro, cardiac, or joint disease that suggests Lyme disease, you do need a laboratory evidence of infection. So what are the lab evidence of infection that are qualified for this? Well, there's a bunch there that the CDC lists, but for our purposes and for most places in Canada, all you can really do is a two-tiered serology. So even if you had a large joint, you really can't send it for PCR or culture because we just don't really have that capability. And there's problems with those tests anyway. So how does the two-tier serology work? First, you start with a sensitive ELISA. It does have poor specificity due to cross-reactions with a number of problems here, such as arthritides, other spirochetes in a previous vaccine. But if it's negative, you stop. If it's positive or equivocal, you go to step 2, which is a Western blot. And if you all remember your biochemistry, bands and intensity of bands, that's what we're looking at here. So the interpretation criteria, it's very important that we use strict criteria. So the CDC has established them, and they'll only accept a positive test if it's using their criteria. It is not applicable for European Lyme. So if you have a patient that came from somewhere in Europe, you have to let the lab know if you happen to be sending Lyme serology, because they do use different Western blot criteria. A negative test here trumps the positive ELISA, and a positive test is evidence for encounter with Borrelia. So considerations when interpreting this test or when using this test is if it's been more than 4 weeks and you have a positive IgM and a negative IgG, it's very unlikely that this is actually a positive test. Seropositivity can persist for many, many years. So unless you have convincing evidence that your titers are going up, then it's really hard to use this in the setting of, for example, recurrent infection. So you have to take the seropositivity in any patient with Lyme disease into clinical context for sure. Some of you may be asking how good the test is. So in the early phase, I'll just draw your eyes to the sensitivity column. The acute and convalescent phase, so if you have erythema migrans and you send serology, it is most likely going to be negative, so it's really not useful. As soon as you start getting into the late stages of the disease, cardiac, neuro, and arthritis, the sensitivity is reported to be 100% or close to there. Specificity, thankfully, is very high throughout the process, thanks to the stringent criteria with the Western blot. So keep that in mind as we go through. And who do we test? So that's going to come up a lot, possibly in real clinical practice here, where you got patients with chronic symptoms and you're wondering if you should be testing them. Well, the CDC recommends that we only test patients that fit all of the following criteria, which are residents or travel to a Lyme endemic area, a risk for tick exposure, and some objective finding. So neurologic disease, carditis, arthritis. So it has to be a swollen joint and not just arthralgias, and it can't be just fatigue and memory problems, that type of thing. That's their criteria. I just want to touch on culture because it is in the literature described as a gold standard test. Obviously, if you're growing spirochetes out of some tissue, then you have a problem. But it's not a good test. It's hard to do. It takes a lot of time. Uses special media, and the sensitivity is actually only 50%. And so we don't do it here. Other unreliable tests include PCR. It has a lot of promise, but there's a lot of problems with it in terms of false negative, false positive. It's not standardized. Urine antigen test, some of you may have heard of this test. It's highly unreliable. There is one study where they tested the urine of the same people 5 different times, sent it to the same lab 5 different times, and got results all over the place. So it's not a very good test. The rest of the tests, some of them do have promise, including maybe an immune complex assay, but not ready for prime time. And this is this bottom one here, serology that doesn't use the CDC criteria. That is a bit of a problem in terms of American and private lab testing. So we'll talk about that. So, so let's take a look at a few cases and put into practice. So case 1, you have a 36-year-old female presenting with a tick on her thigh. She just returned from a 2-day camping trip, and she's asking you, 1, to remove the tick, and 2, and she's very concerned that she's going to get Lyme disease. So what else would you like to know? Yeah. How long? Anything else? Where'd she go? Good. Yeah. Those are certainly good initial questions. So was it an Ixodes tick? You can look at it yourself, and now you can make that judgment, right? Was the tick attached? How long? Engorged? And again, of course, where did she go? That's certainly going to be very important. So everyone know how to remove a tick? Well, we'll show you. I know some of you are savvy. I was not.
Feeding on you and salivating. And so when you burn the tick, it salivates even more. Pretty much you're scaring it, and it just goes bleh into you. And that's what you want to avoid, because in the saliva you have potential pathogens. So you want to avoid that. The safe way to remove ticks is to take your tweezers, and you want to go as close to the skin as possible. And you want to hold on to your tick, and what you're going to be doing is you're going to hold on and you're going to pull straight up. Slowly, steadily. You don't want to twist, you don't want to jerk, you just want very steadily to hold on to your tick.
You guys let
like
do
this.
That to you? Kind of weird, eh?
And pull up. Like that. Now you have your tick. The mouth parts are there. People worry about not having the head stay into you. They don't really have a head to speak of. All they put in there is little mouth parts. They're sinking there.
So clean the area after. Don't burn the tick. Don't put Vaseline on the tick and try to suffocate it. Just pull it out. Here's there was a question on the survey. Thank you for filling out my survey again about tick keys. So we can talk about that or show you that real quick. They seem to work pretty well.
You want to get down close to the skin so that the
That's a
head
dog's
is
ear.
removed at the same time.
Poor dog.
Because if you don't, you leave that in there, it's quite a reaction in the skin. But you can see, here's the tick key going over top of the tick. We're trying to get it off the skin a little bit. There you go. Slide it in.
It's a Lone Star tick.
There it is. So there's
Bam.
the tick.
It's out. Pretty good, eh? All right. Sorry, who said that? Yeah, that's okay. You can pull sideways. You can twist. You can do whatever you want. All right, so does she need prophylaxis? Who wants to answer this question? No, the girl. No? So Amanda says it depends how long it's been on. Right, so this is the study of prophylaxis that I talked about. So 482 patients bit by Ixodes scapularis. They were either given antibiotics or placebo within 72 hours, and they were followed for 6 weeks to look for the development of erythema migrans. And in the treatment group, the one patient out of 235 ended up getting Lyme disease, and only 8 in the placebo group, so 3.2%. That's a relative risk reduction of 87%. No one got objective extracutaneous manifestations from this problem or from the initial bite. So based on that, based on what we know about engorgement, the IDSA recommendation is one dose of doxycycline for 200 milligrams once when all of the following are met. Ixodes scapularis tick, on for more than 36 hours, prophylaxis given within 72 hours, local tick infection rate is high, more than 20%, and doxycycline isn't contraindicated. If doxycycline is contraindicated, for example, kids, pregnant, or kids less than 8, then they recommend just watching and waiting and looking for the development of erythema migrans rash, because you can treat that just as well. And there's no evidence for amoxicillin or something else for prophylaxis.
Mike,
Yes?
you were saying before in that study that it was an infection rate of about 3%. Is anywhere going to be greater than 20% infection rate?
No, sorry, the rate of developing Lyme disease was 3% in that study. Their tick infection rate's like through the roof. Yeah.
Thank you.
Yeah, okay. So, this is the tick you took off. Is it Ixodes scapularis? Yes, it is. Is it engorged? No. So, that tick looks something like one of those two, probably, somewhere in between, maybe closer to the first one even. So, and it definitely doesn't look like that one. So, it's not engorged. Does she need prophylaxis? Nah. Okay. So, it's an Ixodes scapularis tick, but it definitely has not been on for 36 hours. It's definitely not engorged. So, you stop there. You have a discussion with her. It may not go so well, but now you're armed with some information. Okay? Case 2. You have a 39-year-old male. He's a tree logger, and he's in your ED. He's got a growing rash for 2 days on his leg, He's fatigued, he's got sore muscles and joints, and he's got chills for 3 days. This is what his rash looks like. What's the rash? Dr. McCarter, what is this rash? And it's not the other one you said, the scaly one. Right. So, how would you manage this patient? Who wants to venture that one? Shabazz, you going to treat this patient? You're going to send serology? Yes, serology? No serology. So this is where we are. So this is erythema migrans. The serology is low here, and that's why. So the serology is most likely going to be negative in erythema migrans. It's reported in 70-80% of patients with Lyme disease. They may or may not have a viral syndrome. It's round, it's oval-shaped, and it comes 3 to 30 days after the bite. Persists 3 to 4 weeks without treatment. 5 centimeters usually or more, continues to expand. You may have multiple lesions. That's suggestive of early disseminated disease. And it's not usually itchy or scaly, so that really differentiates it from the tinea. The key differentiation here that I want you guys to know about is the tick itself or any other insect bite can give a red reaction to the tick bite itself, to the antigens, to the toxins it has, and that usually occurs within the first 2 days and goes away within 48 hours. So if the red lesion comes in within 48 hours, it's not erythema migrans. If you want to prove it to yourself it's not, you wait till 3 days, and it should be expanding if it's erythema migrans rather than getting better. So here's classic EM. Here's your bullseye. Which one of these is erythema migrans? Left? Dr. Lacroix. Yes, thank you. Which one? The third one. Robert, what do you say? Well, that's my patient, yeah? All of them, yes. Oh, good. So, Francis Bakewell and Amanda Collier, right up front. So, in the early phases of the disease, erythema migrans, all it can look like is a red macule. Actually, most of the time, it looks like a red macule in the early phases of disease. Eventually, it does clear out to the one on the very right there. And about 30% of the time in the early phase, it's actually a central erythema that characterizes it. There are other forms, so you can have this necrotic center or this vesicular center. This is going to start making you think about something like MRSA. And so if you're not sure, I mean, doxycycline treats that too. So, and then you can get multiple rashes. So co-infection, this is something that I didn't know about before, but the Ixodes ticks can carry Babesia and anaplasmosis. So if you have someone that has a tick bite and they have more than just myalgia, low-grade fever, let's say they may even have that rash, but let's say they look really sick, they have high fever, and for whatever reason you send their blood and they have some cytopenias, leukopenia, anemia, thrombocytopenia, that would make you really start thinking about co-infection with either babesiosis or with anaplasmosis, and obviously you're probably not going to take that upon yourself, but you'll talk to ID about that and get some help on how to diagnose those problems. So the treatment for this patient, this patient has erythema migrans, you're done. Don't send serology because it's going to be negative, and then you're going to be left with trying to interpret that. Treatment options include doxycycline, amoxicillin, cefuroxime, and the recommendations are 14 to 28 days. I recommend just keeping it simple and going 14. Do inform your patients that they can get a Yarish-Herxheimer reaction. Does anyone know what that is? Mumblings? So remember syphilis back in the day when you treated syphilis in the first 24 hours when you started giving antibiotics, you would get worse. Because the spirochetes die, they release their exotoxin and antigens, and you start getting worse myalgias. You can even get fever and hypotension. Let them know that it's not life-threatening. It can, but they can feel worse in the first 24 hours. NSAIDs are purported to help with this. Prognosis, the rash usually gets better in 1 to 2 weeks with treatment. Subjective symptoms, unfortunately, can linger. 25% of patients at 3 months, 10% at 1 year. Objective extracutaneous manifestations are exceedingly rare. Okay, moving along, case 3. So you have a 40-year-old male in the ER with malaise, palpitations, and fever. He's been camping he went camping three weeks ago in Maine. He has no EM. He's been reading a lot about it on the web and all that stuff, and he's been looking for this rash. He doesn't have it. His initial vitals, he's a little on the low BP side. His heart rate's a little slow. First ECG shows first-degree AV block, PR of 305 milliseconds. His second ECG is, I'll save you the squinting and all that. It's third-degree AV block. Could this be Lyme disease? This is a Lyme talk. This is obviously Lyme disease. But the question is, how should you manage this patient, and what can you expect from this block? So just to reorient you guys, this is early disseminated disease. This is carditis. The vast majority of these patients will have positive serology. Usually it happens 2 to 8 weeks after the initial infection. You get the heart block type symptoms, and the heart block is usually acute onset, and the hallmark here is that it fluctuates. It can go from first, second, third, and back, cycling very quickly. It is the myopericarditis is mild, self-limited. Usually only get a bit of non-specific STT changes. And what can help you with the diagnosis is a lot of the time there are associated features such as erythema migrans, a swollen joint, some neurologic findings. So, for example, if you had someone with carditis and a cranial nerve palsy, you should really suspect that this is Lyme disease. So the diagnosis, according to CDC, should be made on clinical grounds only if you have a concurrent erythema migrans. The rest of the cases, they're saying you should confirm with serology. I think in this case, it's probably reasonable to make the diagnosis clinically, and I think it's probably reasonable to make it clinically in the following scenarios. Obviously, if there's a current erythema migrans, but if they have coexisting neuro, joint, or cardiac, or carditis, or sorry, if they have concurrent neuro joint disease that's consistent with Lyme, I think it's reasonable to raise your antenna to that diagnosis. History of tick bite with no other reason for heart block is actually would raise my antenna pretty high. Prognosis. So what can this patient with a third-degree heart block expect? Well, actually, it's going to get better. Temporary pace is only required in 15% of people. The high-degree AV block usually gets better in a week. The lower grades, like the PR prolongation, will get better in about 6 weeks. And it's actually not clear if antibiotics help this, but certainly you'd want to give this patient antibiotics to prevent the later sequelae of the disease. So ED treatment and disposition, if they have a first-degree AV block and it's consistently less than 300, you can give them doxycycline and send them home. We're not doing that with this patient. In this patient, they have a high-degree AV block. Our disposition is pretty easy. We'll admit them to cardio and get ID involved. We'll also send Lyme serology for confirmation. Now, clearly, this is a fairly easy case in that he's got that history of being in Maine. He's got a low-grade fever. He's got new heart block without any reason. But if it's isolated carditis, a new carditis, and a patient maybe only had a flu-like illness recently without a clear history of a tick bite, that makes this diagnosis very difficult, obviously. So, but think about it: summer months, right? So, case 4. 42-year-old female in the ER with 8 days of gradually worsening myalgias and neck stiffness. She's seen in the ER on day 3 of her illness, and she's diagnosed with viral meningitis without an LP. She lives in Ottawa. She's an avid trail runner. She takes her socks off at the end of her trail runs and dips them into the pond and stuff. On exam, she's got a low-grade fever, and she's got mild neck stiffness. Her exam is otherwise normal. You perform an LP which shows the following. Would anyone care to interpret what that LP looks like? Crickets. Dr. Dewhurst looks like he's got an answer.
Well, it looks like a viral meningitis.
It looks like a lymphocytic meningitis. You're very smart. Yes. Viral meningitis, yes. It could be Lyme disease, right? Probably could be Lyme disease. So the question is, how do we deal with these how do we deal with these differently if it was viral? So just to reorient again, early disseminated disease, meningitis, Serology should be positive. This occurs weeks to months after erythema migrans. Occurs in 15 to 20% of untreated Lyme. Neurologic disease altogether occurs in 15 to 20%. Meningitis is actually fairly uncommon for the neurologic. You only get 2% of the time. More common is the cranial neuropathies, around 10%. The key to the meningitis, though, it's a subacute onset. So usually viral meningitis, they come in within a few days. These patients, their onset, they usually actually only present a week out. So it's usually very mild, and it's just progressively accumulates to the point where they seek medical attention by, on median time, 7 days. They can get a painful radicular neuritis in a dermatomal distribution. Encephalomyelitis, which kind of mimics MS, is thankfully very rare. The later version of this neurologic problem, or the neurologic Lyme disease, is again a stocking glove distribution peripheral neuropathy and a subtle encephalopathy, so where they have sleep disturbance, mood disturbance, a little bit of confusion, memory problems, and this is one of the manifestations, obviously, that leads into the controversy of whether people have a chronic manifestation of Lyme disease. And then again, encephalomyelitis, which is rare. So lymphocytic meningitis, worth looking at the differential diagnosis. So this patient has lymphocytic meningitis, and I would argue that her diagnosis is either viral or it could be Lyme. The other few here, Rocky Mountain, you should have a rash and high fever. Fungal, normal people don't get fungal meningitis. TB, same. And then with TB, you would also expect lower glucose, higher protein, and some risk factor for having TB. So we're still in viral versus spirochete here. Clues to Lyme. So think about this, and particularly in the summer months, and the same with the carditis, for example, is that if it's a subacute onset, so if they're presenting and they're still having symptoms 7 or 8 days out, clearly if they've had a presence or history of erythema migrans, a tick bite, if they're in the warmer months. So if in the summer months you get this viral meningitis, stop and think if this could be Lyme. And a cranial nerve palsy with meningitis, cardiac symptoms, joint symptoms, that really should solidify your diagnosis. On the topic of neurologic Lyme disease, when cranial neuropathy, Dr. Gatien, may I? Okay. If you have a bilateral or recurrent cranial nerve 7 palsy, that's pretty much slam dunk for Lyme disease. There's a few other things that can do it, like Guillain-Barré, MS sarcoid, but really think about Lyme disease in the right patient. The other things that can guide your suspicion is the presence or history of erythema migrans, kind of like in the case of meningitis. So really, in the summer months, think about it. Dr. Gatien actually yesterday just saw a patient with Bell's palsy, and they had erythema migrans on their arm. So, cool case. As far as treatment of neurologic Lyme disease, if it's just an isolated cranial nerve palsy, they go on doxycycline for a couple weeks. If it's anything CNS, they get IV therapy, probably admission, and an ID consult. Even without treatment, the meningitis, usually self-limiting, doesn't cause a lot of lasting sequelae, except for the usual or the common manifestation of fatigue, etc. Radicular neuritis can persist, but generally subsides in weeks to months. So in this case, this patient had lymphocytic meningitis for over a week. You started suspecting that this could be Lyme based on time course and endemic area. Again, still, even that being said, the diagnosis isn't clear. What I would suggest in this case is get a detailed travel history, really do a full body search for erythema migrans. You would probably want to get ID involved, and what could help is you send the 2-tier serology, and you could also, to help your diagnosis, get an ECG, see if they have AV block. This is just something I wanted to show. CHIO, this is a tip I got from one of the survey respondents. CHIO has a pathway, so this is kind of cool. I won't go through the whole thing with you, but this could be pretty useful for us if we had something like it. I don't think we have anything like it. So they have a kind of when to suspect it and how to treat it and which consults to get. It's pretty cool. So as I think we're going to get more presentations for Lyme disease, I think this could be a pretty useful tool. Yes? Maybe. I don't know. Okay. All right. So now we're getting into the home stretch here. Got some time. Started a little late. So case 5. 33-year-old female. Worsening fatigue since last summer. So year and a half. Shabazz just rolled his eyes. Don't do that. Suppress your preconceptions. Okay. So she went camping at Murphy's Point last year. That's in the Perth area. Today, her vital signs are normal. She has no objective findings on exam. She is requesting you send a Lyme test for her because there's no other reason why she would be tired. And she asked you, didn't you hear about Avril Lavigne? Everyone's heard about Avril Lavigne? So just to bring it back, who do we test? So the CDC recommends we only test patients who are in an endemic area, who have a risk of a tick bite, or who have objective manifestations of a disease. And there's a reason for that. So if we go back to our test characteristics, we have a very sensitive test in the later stages of the disease. We also have a specific test throughout the stages of the disease. But as you all know, the positive predictive value of any test is related to its pretest probability or its prevalence in the population. So I did a little number crunching. So let's say this patient had a 20% chance. You gave this patient a 20% chance of having Lyme disease based on did they have objective manifestations, whatever. That gives them a positive predictive value, assuming our test is 99% sensitive, very good test characteristics, 99% sensitive, 98% specific. So what happens if, at best, you gave this lady a 5% chance of having disease? Some people would say she has like a 1% chance. But let's give her the benefit of the doubt, she has a 5% chance. What do you think her positive predictive value is going to be? It's going to be lower, but it's surprising. So 72%. So 3 in 4 of those will be true positives. So the problem we get into is there's a lot of Lyme disease testing done for vague symptoms that are not related to Lyme, and people will get false positives. They will get put on long-term antibiotics in some cases, and they will have that diagnosis with them probably for a long time. That being said, in talking to some ID experts, some ID experts will send serology if there is no other cause, they live in a Lyme endemic area, and they have a risk of tick exposure, so they not necessarily with the objective findings. And it'd be nice if there was a clear-cut way to do it, but it really isn't that easy. So case 5 continued. Based on what you know about positive predictive value and prevalence, etc., you choose not to send Lyme serology. But she comes back to the ER several months, and you happen to pick up her chart. Dr. Ritzy, you picked up her chart. She's looking for you. Okay? And she presents you with this. What is this? This is a lab report from IGNX in California. It's a Lyme IgM Western blot. That's kind of weird, right? Because we're talking about someone with a chronic illness. But it's an IGNX interpretation that is based on internal validation studies. And what it says, what really should draw your attention is that the IGNX IgM result is positive, the CDC result is negative. So what do you do with that? How do you navigate that? How do you have this discussion with this patient? Well, I'll help you out here. So private testing is notoriously a problem. So, for example, IGNX, that is the one that in Palo Alto, California, that everyone's been talking about. So they previously used to use that urine antigen test that I told you about that's all over the place, false positives, false negatives on the same person. What they use nowadays, so they got reprimanded for that and they don't do that anymore, but they use a variant of Western blot but with more liberal criteria. And Fallon and others, Fallon, who is a Lyme activist, was trying to show that the Western blot using the IGNX criteria improves the sensitivity of the test. But what he probably didn't realize he was showing to the world was that maybe I'll just describe what he did. So he sent Western blot, he sent samples for Western blot testing to university lab, large commercial lab, and 2 Lyme specialty labs. So he showed that the sensitivity of the labs were the same if you use the CDC criteria, and the sensitivity of the Lyme disease labs improved when they used their own in-house criteria. But when they used their own in-house criteria, their specificity was so bad that 23 out of 40 of healthy controls were labeled as Lyme disease. So, problem, right? So that opens the door now to why did she want to be tested in the first place? Why did she send her blood to an American lab? And why would it be any different than our tests? So Lyme disease is ripe for controversy because there's a lot of uncertainty. So sometimes Lyme disease doesn't cause objective symptoms. You get Lyme arthralgia with arthritis. In the initial study by Alan Steer, the guy who discovered Lyme disease, he described 18% of patients having arthralgias without arthritis. There is this phenomenon of Lyme encephalopathy, which is probably pretty hard to objectify. And after proven infection, a minority of patients, infection and treatment, a minority of patients will still have subjective symptoms. So they'll have fatigue, myalgias, cognitive slowing, memory problems, etc. And we're not sure what causes this, whether that's a persistent infection, it's an autoimmune reaction, is it a reinfection, or is it another diagnosis? We haven't fully characterized that. Just like we haven't characterized other chronic fatigue syndromes, we're not sure. So what we do know is that these same symptoms occur in about 2% of the general population. That would mean the chronic fatigue and fibromyalgia subset. So the math here is that you have a disease that can cause chronic fatigue, arthralgias, cognitive slowing, a disease that has a perception of imperfect testing, and it is imperfect, but I think it's actually pretty good. And chronic fatigue symptoms in 2% of the population. So that leads to a lot of people with chronic pain and fatigue hoping for an answer, right? So that has spurred this whole, what's called Lyme Wars, or the big Lyme controversy, and a lot of Lyme activism. We'll do this one.
Became bedridden last October, and I was in Los Angeles, and it was literally the worst time of my life. And
This is
I was seeing every specialist and literally the top doctors, and they were just they would so stupid. They would pull up their computer and be like, chronic fatigue syndrome, or why don't you try to get out of bed, Avril, and just go play the piano? It's like, are you depressed? This is what they do to a lot of people that have Lyme disease. They don't have an answer for them, so they tell them, you're crazy.
So, there's people like Avril. There are people like Crystal Hefner, and I'll just read this to you. So she came out and gave herself, or was diagnosed in March with Lyme disease. And so it says, if you have ever gone hiking, please get tested for Lyme disease, #Lyme disease. The best lab test to do this is IGeneX. They are based out of Palo Alto. I was diagnosed a few days ago and have a long road ahead of me. Supposedly, you get it from ticks, but I have absolutely no recollection of being bit by or having a rash or anything. Most importantly, there are so many of you probably carrying Lyme disease that you don't even know it, probably because the ticks can be the size of specks. The symptoms are vast, and when it has been left untreated for a long time, can turn into MS, Alzheimer's, Parkinson's, dementia, and ALS. Crystal Hefner. Okay, but I want to go on this with an unbiased opinion and see what the truth is, okay? But let's carry on. So, despite all this, despite media attention, internet awareness, and activism, the IDSA essentially stomps on this. So they say that Lyme is rare, it's hard to catch, it's easy to diagnose based on clinical features and testing, it's easy to treat and cure, the chronic infection really probably doesn't exist, and chronic Lyme is a bit of a faith-based opinion. So, at the center of this is patients that feel that conventional medicine has failed them. And this has led to what's called Lyme literate MDs, if you heard of this, LLMDs. That has spurned private labs, that has led to protracted antibiotics, pseudoscience and alternative treatments, and political activism. So I'll touch a bit on a couple of these. So political activism has culminated into this ILADS, or International Lyme and Associated Disease Society, and their stance is that it's not rare, can be found anywhere. Co-infections are common. Tick bites, erythema migrans often goes unnoticed, and it does go unnoticed sometimes. Commercial lab testing is rife with false negatives. Chronic infection does exist, And some people have either recognized or persistent infections that require prolonged antibiotic to eradicate the infection. So you can see there's two major camps, right? IDSA versus ILAD. Political activism, just to give you a flavor of what's happened out there if you weren't aware. In the 1990s, a bunch of university scientists and public health officials were accused of intentionally underreporting and underdiagnosing Lyme disease. Some of it was related to the activists saying that the doctors were in the coffers of insurance companies so that the insurance companies wouldn't have to pay out for years of antibiotics. Researchers were then accused of financial conflicts, patents, grants, pharmaceutical funding. This actually caught attention of U.S. Congress in 1993 that led to an investigation which found no evidence to substantiate. In 2000, activists looked at the CDC for dishonest science, as well as the NIH, and this led to a bit of an investigation again with no evidence to speak of. This was a big one if none of you have heard of it. So in 2006, Richard Blumenthal, who is a known Lyme activist and Lyme supporter, was then Attorney General of Connecticut at the time. He threatened the IDSA with antitrust litigation because there was conflict of interest in terms of failure to screen for conflicts of interest within the group and failure to include someone from an opposing opinion on the panel. So the IDSA agreed to a independent review, and the independent review in 2008 concluded that the IDSA guidelines were solid. Except for, which I think is kind of legit, the Lyme activists point out that 7 of 8 panel members of the independent review were on the IDSA, and the ethicists that screened the panel members for conflicts in this independent review were paid by the IDSA. So it's not like clear cut, like they're squeaky clean either. So some of the pseudoscience, just to let you know about Lyme diagnoses. So we talked about specialty laboratories. We talked about non-validated tests, but some of these diagnoses are happening based on clinical impression alone. You're tired. You must be Lyme type stuff. There's been some crazy stories published in Forbes magazine, for example, of a doc who made diagnoses over the phone across the country, never saw the patient, never met the patient, referred them to his own IV lab, his own PIC service, and made millions of dollars. This is a guy who has like a grand piano and a waterfall in his clinic. And some of these patients are subject to months to years of antibiotics, and some of the complications, obviously, PIC line sepsis, DVTs happen. Some people are on prolonged ceftriaxone and they get pseudolithiasis from that. Some of the alternative treatments. Any of you know what DNP is? So it's a substance banned by the FDA for like 50 years, and it used to be used for cutting, and it causes uncoupling of oxidative phosphorylation, and it causes fever. And they tried to use that to kill spirochetes. They've been injecting patients with hydrogen peroxide. They've been injecting patients with bismuth that actually led to a death and fine and penalty, etc. I think jail time. Rife machine, anyone know what that is? It's this machine that uses like electrical magnetic fields to match the electromagnetic signal of a spirochete and kills it, I think. Colloidal silver, that sounds like something you should use on like a werewolf. Vampire. Anyway, so that being said, I went into this wanting to look at the objective evidence and to say, well, are they onto something here? Could this be true? Is Lyme causing all these problems? So there is actually evidence for persistence of infection. Sorry, I'm running over time. Is that okay? I only have a few minutes left. There's some studies of animals, for example, in these monkeys, where they were infected, treated, and then later were found to have viable spirochete left in their system. There's a study in 2006 where in vitro they showed that the bug can go into intracellular hiding places. In 1995, they showed that the bug can go into a cystic form or an L form and evade antibiotic killing. This hasn't been shown to happen in vivo, but there is an in vitro study. And in 1989, this European study, it showed that these 6 patients, they'd been treated over and over again with antibiotics, and they had positive skin cultures, some of them CSF, and this same group actually later found spirochete in someone's eye. It's crazy. Evidence of co-infection. This is something that comes up a lot with these patients. If you look at their blogs, they say, you know, I'm co-infected with babesiosis, Bartonella, etc. There is no evidence to substantiate chronic anaplasmosis, chronic babesiosis, because babesiosis usually causes fever and symptoms, and parasitemia, or tick-transmitted Bartonella. The answer for protracted antibiotics, well, there's been 4 RCTs done on this, and one of them actually done by a Lyme activist group. And the key here is, one of the keys here is that they've enrolled 502 patients, but they had to screen almost 7,000 because most of the patients that were looking to be enrolled in these studies didn't have any objective evidence of ever having Lyme disease. 2 of the studies, they gave them 3 months of additional antibiotic, IV plus minus PO. 2 other studies, so they showed no benefit. 2 other studies were equivocal at best. Some subtle benefits early on that disappeared. None of the authors included the antibiotics outweighed the risks, and none showed evidence for persistence of infection or co-infection. Here's a study done by Stier, who is the founder, one of the founders of Lyme disease, the initial doc who went to go characterize it. And he reviewed 788 patients referred to his Lyme disease clinic. And he found that 23% had active Lyme, 20% had previous Lyme and another illness, usually chronic fatigue. And then he found almost 60% didn't have Lyme disease. And he says that some of them had borderline positive tests at another lab. He doesn't say it outright, but I think what he's getting at is that they're at private labs. So how do we make sense of it all? And we're coming right down to the end here. So what I think we can say is that some patients develop subjective symptoms after confirmed Lyme disease. We don't know what causes it. 2% of the non-Lyme affected patients have the same symptoms, and most claiming chronic Lyme never had an objective diagnosis. There is some evidence to suggest that Borrelia persists in some tissues, but we're not sure what role it plays. We know that seronegativity is extremely rare in late disease. Co-infection with babesiosis and anaplasmosis doesn't play a role, and protracted antibiotics should not be part of the solution. When I asked you guys, do you believe persistent infection is responsible for the symptoms of chronic Lyme disease? Most of you said no, but most of you, or half of you, also said, well, you know, you kind of left the door open to interpretation, maybe, right? And I think one of the historical things to think about is H. pylori here in this case, where it was very skeptical. Everyone was very nay about whether that causes peptic ulcer disease. So my synthesis of all this is that the available evidence doesn't support persistent infection as the cause of post-Lyme syndrome, but I don't think it's impossible. Regardless, I know it's quite clear that protracted antibiotics is not the answer, and I think our job in the ED is to recognize objective Lyme, so we've gone over that today. Avoid and suppress your preconceptions, and if they have new complaints, they're coming to you in the ER, treat that as any other. So resolution, she has an IgNX criteria positive, CDC negative. She does not have Lyme disease. Suggested approach would be to discuss that, if you can, have an open discussion about the accuracies of the CDC 2-tier testing, discuss the false positives of the private lab now that you know about that study, and she should continue to follow closely with her family doctor, and if indicated, consider alternative diagnoses. So there's a few take-home points that I'd like to leave with you today. One is just remember the indications and rationale for Lyme prophylaxis. Those are them. We'll go through them all. 2, erythema migrans is often not a bullseye rash, and most of the time in the early disease, it's not. Looks like that. Remember that. 3, if you have someone with a viral syndrome, carditis, neuritis, neurological problem, cranial nerve palsy, arthritis, in the summer, stop and think, could this be Lyme disease? And remember your early disseminated and late manifestations of Lyme disease, and that the serology goes up as your disease progresses. And 4 is the Lyme controversy is far from over. All right. Special thanks, Dr. Gatien, Dr. Marc Desjardins from microbiology, Dr. Bill Cameron from ID, and Dr. Ruchi Murthy, who's an ID fellow who helped me out a lot with this presentation. I want to leave with you one last video.
You have Lyme disease. We miss you. Kevin's biting me. Come back soon. Here's a drop.